Okay, thank you very much. Welcome to everyone. I'm going to chair this session of posters about bronchiectasis. And just remember to the presenters that they have 3 to 5 minutes, and at the end, they will receive 1 or 2 questions, not more than that. The first 3, apparently they are not here, 2 from Atanasio Rodrigo, 2 posters, and 1 from Roberto Cabrera. I don't know if they will join later on. Let's start with the first one from Megan Crichton from United Kingdom. Validation of the bronchiectasis impact measure BIM, a novel patient-reported outcome measure. Please, Megan, go ahead.
No, nothing's happening. Yeah, it's not coming up.
No? Try again.
No, there's nothing there to say share.
No? At the bottom?
No, it's not there. It's not there.
It's not there?
I can't even see the bar. It's not like
No?
what it was in the IT session. There we go.
Okay, now Megan.
You got it now?
Yes.
There you go. Okay, thank you very much, Tori. So I'm Megan Crichton. I am part of the Chalmers team here in Dundee, Scotland. And this is just a very quick overview of a new patient-reported outcome tool that we have validated just recently. So we know that bronchiectasis impacts negatively on patient quality of life, and that has been reflected in the number of studies that involve at least one patient-reported outcome measure or questionnaire in their endpoints. However, a couple of recent reviews have shown that the questionnaires that are in use have shown that the questionnaires are inconsistent and are quite poor at determining significant therapeutic improvements. We did an observational study a couple of years ago and asked patients to review the questionnaires that are most commonly used, and they identified key limitations, including complexity, lack of disease specificity, and difficulty with interpreting the scales. So with all this information and with help with some bronchiectasis patients, we developed the Bronchiectasis Impact Measure, or the BIM. This is a simple 8-item self-administered questionnaire designed to measure patient perceived health impact at baseline and after a follow-up period. The items being measured are cough, sputum, tiredness, breathlessness, general health, daily activity, control, and exacerbations. The BIM focuses on disease impact rather than asking about the frequency or severity of any of the symptoms. To validate the questionnaire, 173 patients with bronchiectasis completed the BIM and also the Quality of Life Bronchiectasis Respiratory Symptoms Questionnaire. They did this at baseline, repeated it at week 2, and then again at 6 months. We measured internal consistency, test reliability, and construct validity. We also looked at responsiveness by looking at the changes of data during an acute exacerbation, and we looked at MCID, which is the minimal clinical important difference. We analysed this using conventional distribution-based methods, but we also wanted to demonstrate whether a patient-derived MCID could be developed in support of personalising therapies. The results of the study showed that those patients with more severe disease and those with comorbid COPD rated their impact of quality of life significantly higher, and that's shown in figure 1. When we compared the BIM to the Qual-B, we realised that the BIM was actually able to detect the range of disease impact more sensitively. And this is thought to do with the difference in scalings. So Qual-B uses a 4-point categorisation. The BIM uses a 10-point visual analog scale, which can actually be scored at 0.1 increments. Figure 2 shows some nice examples of this increased sensitivity. So while some patients were able to answer the qual B saying that they did not cough at all, they were still able to measure an impact of their cough on the BIM visual analog scale. Sorry. In regards to responsiveness, there was statistically significant changes in all BIM domains during an acute exacerbation. And when we looked at the MCID, it was noted that the patient-derived MCID had total agreement with that from the distribution-based methods, and both suggest that all 8 items show the minimal clinical important difference of 1.5 points. So to conclude, the validation study has validated a simple bronchiectasis-specific questionnaire capturing patient perceived quality of life while allowing them to determine their own MCID and monitor changes of their quality of life with our medical intervention. Although just to last say, we do acknowledge that further validation and an interventional trial is needed. Thanks for listening.
Thank you very much, Megan. Thank you for the results. This is very interesting. I have a couple of questions. One, you said that this has to be validated in another population, external, no?
Yes.
This is the next step.
Yeah, so at the moment we've only validated it in a single centre study here in Dundee. So we that's a small population of the bronchiectasis characters, although it did reflect the wider European cohort. Although we looked at the sensitivity in regards to a negative impact from exacerbation, we do need to look at something from an interventional, so a beneficial impact. Okay, my second question is in terms of the time that is needed to fill this self-report. How much time? So the patients actually commented themselves it was much quicker than the ones that they're used to filling in. So you would be looking at about 5 to 10 minutes maximum. It's very simple, 8 visual analog scales. And finally, did you measure did you look at the questionnaire for Pseudomonas chronic infection? So not specifically for Pseudomonas, but we did look at gram negative. For gram negatives, yeah. Yeah, so there was statistical increases in control and the exacerbations, which isn't surprising, seeing as they're the driving forces of exacerbations. So thank you very much, Megan. I repeat that these are very interesting and important results to be used in the next studies. Thank you. Thank you. Okay, so the next poster, the presenter is Maria Carmela de Buono, Voice of Patients in Bronchiectasis, a social media analysis.
Are you able to see my screen?
Yes.
Okay, thank you very much for the opportunity to be here and to present our work, Voice of Patient in Bronchiectasis, a social media analysis. In this poster, we present social media as a novel approach to listen to the voice of patients. Conversation on social media can offer unprecedented insight on how patients live with their disease, on how they think, on their condition, and also about their emotions. This is the first study using social media listening to understand patient perspective of living with bronchiectasis. Let me briefly introduce the methodology we used. We conducted a comprehensive search around bronchiectasis on several social media platforms. The analysis has been conducted on discussion posted between January 2018 and December 2019 in 5 different languages and across different geographies. The aim of the study was to obtain patients' and caregivers' perspective on symptoms, treatment, and burden of the disease. Conversations were extracted using keywords and terms related to the disease. Let's move on to our findings. Over 27,000 mentions online of bronchiectasis and its management were retrieved, 38% of which were posted by patients and caregivers. And the figure on the right shows the volume of mention across the different geographies. And as you can see from the graph, a large volume of mention were captured across Europe. A huge number of online conversations were related to symptoms and to diagnosis. If we focus on symptoms, as you can see from the first row of the figure, cough, shortness of breath, and mucus production were the most frequent complaints among patients. From online conversation, we have also found that a large group of patients were misdiagnosed, and they undergo multiple rounds of medical consultation, leading to a delay in the proper management of the disease. This slide is dedicated to the emotional journey of patients living with bronchiectasis. Starting from the left, patients are tired because they struggle with daily symptoms and respiratory infection for years before the diagnosis. They feel confused also about the process related to the diagnosis and frustrated about not receiving the right treatment. Once they reach a diagnosis, fear of reinfection and side effects of treatments, and also the uncertainty regarding the future life with the condition, were the most prominent emotion discussed by patients. So to conclude my presentation, social media listening offers an innovative source of information revealing deep insight into patients' history and, more importantly, emotions. This can complement more traditional approaches to drive a more patient-focused drug development. And from our study, cough, shortness of breath, and mucus production are the most burdensome issues for patients. And also, increased awareness of bronchiectasis among physicians is fundamental in providing the best support to the patients. And last, it's very important to highlight that genuine patient perspectives are crucial in addressing patient needs. Let me please acknowledge and thank all the authors who contributed to this work, and thank you very much for your attention. Thank you.
Thank you very much, Maria Carmela. Very interesting results as well. And if I understood well, 20% of the news or the press releases or something were about patients who don't know that they have bronchiectasis.
Yes, exactly. It's not the number of patients, it's the volume of mentions. So the categorization is not on the number of patients, but on the number of conversation. And these conversations are on social media, blogs, and so on. And there is a huge number of discussion about the misdiagnosis or the fact that there is a lot of time before having a right diagnosis. And so they have to do lots of medical consultation before having a diagnosis.
Okay, but and then is there any explanation about more news and more conversations in Europe compared to the other continents?
Yeah, one explanation could be because we also tried to reply to this question. One possible explanation could be the fact that, for example, in the UK, there are several patients associations that are really able to engage people on social media. And so through their forums and blogs, engage people to share their experience. And so one of the possible explanation is this one, the fact that there is an engagement online that is really important in some countries.
How many or how much the percentage was in relation to cystic fibrosis, bronchiectasis?
Sorry, but we don't have the specific, let's say, numbers with respect to non-CF or CF because it's a more qualitative, let's say, research. So we don't have the exact number of the population. We don't have the categorization by the type of bronchiectasis. Yeah.
Okay. Thank you very much.
Thank you.
Hello, Michal or Mitchell. I don't know how to.
Hi, Tony.
Hi.
So
then you can take the word.
Yes, thank you very much. And sorry I've not been here from the beginning because I was presenting my own poster in a different session. So if you can just let me know which of the poster were already presented.
we have to go back, and now Roberto Cabrera. Hello. You have to present Roberto Cabrera. Hello, Roberto.
Hello.
Okay, so you will present automated computed tomography lung densitometry in bronchiectasis patients. Is that right? And you have 2 posters here, right?
No. No, it's the third. High levels of resistance.
Oh, sorry.
Okay.
The third one. Okay.
The third one.
So high levels of resistance to recommended antimicrobial agents in Pseudomonas from patients with bronchiectasis.
Exactly.
So go ahead.
Is okay the screen?
Yes.
Okay. How we know non-cystic fibrosis bronchiectasis is a chronic structural lung condition that facilitates chronic colonization by different microorganisms. One of the main pathogens involved in chronic colonization and acute exacerbation is Pseudomonas aeruginosa. The objective of our study was determining antimicrobial susceptibility, the molecular mechanism of resistance involved, and the molecular epidemiology in Pseudomonas aeruginosa strain isolated from patients with bronchiectasis. For this, a prospective observational study was carried out in hospital clinic. A total of 43 strains of Pseudomonas aeruginosa were isolated and characterized from sputum of patients with bronchiectasis. The antimicrobial susceptibility to 9 different antimicrobial agents was performed by the KIB government. Molecular characterization of each resistance mechanism was screened by PCR, RT-qPCR, and sequence. Molecular epidemiology was performed by multilocus sequence type of 7 housekeeping genes. As a result, about antimicrobial susceptibility, we found important level of resistance to astronacin, ciprofloxacin, meropenem, imipenem, amikacin, and tobramycin. And the strains were located in 4 different antimicrobial profiles: pan-susceptible, moderate drug resistant, multi-drug resistant, and extensive drug resistant. About mechanism of resistance, mutation in GIR-A, GIR-B, PAR-C, and PARI genes were found in ciprofloxacin resistant Pseudomonas aeruginosa strain. Our study showed that a high number of mutated genes were related with the increase of minimal inhibitory concentration in the quinone resistant domain region. By the other hand, the presence of different beta-lactamases were detected, mainly black oxaphysti, in the strain resistant to beta-lactam. The modifying signs, the modified aminoglycosin signs, were the responsible resistant to aminoglycosid, and the NCR1 gene was the responsible of resistance to colistin. The gene expression analysis showed mainly overexpression in the MXABOPR efflux system over the other efflux systems. Result that coincides with the high number of mutations in post-translational regulation gene associated with milling. By the other hand, OPRD loss and different mutation patterns found were associated with resistance to carbapenem. About molecular epidemiology, 27 clones were identified. The most frequent clones were 619, 676, 532, and 109. And these clones were distributed in 4 different clonal complexes. In this part, we want to highlight the wide dissemination around the world of high-risk cloning, strains of Pseudomonas aeruginosa, multi-drug resistant, and extensive drug resistant. We consider that the most frequent clone found in our study are high-risk emerging clones in Pseudomonas aeruginosa associated with bronchiectasis. Finally, as a conclusion, we have that the high level of resistance to first-line antimicrobial recommended in guidelines, the great diversity of mechanism of resistance found, and the wide circulation of high-risk clones treating the treatment of bronchiectasis and eradication of Pseudomonas aeruginosa associated to this disease. By the other hand, low level of resistance to colistin, ceftazidime, and piperazidine tazobactam were found because they are not the first options. However, we must keep the antimicrobial surveillance because the resistance mainly to ceftazidime and piperazidine tazobactam is associated with extended high-risk clones. Finally, resistance to each antimicrobial agent was not ascribed to a specific mechanism, but was determined by the combination of several resistance mechanisms. Thanks for your attention.
So thank you very much. And do we have any questions from the audience or for the other presenters? And can I ask if you try to correlate with patients' histories? So if they received a certain antibiotic, are they more likely to be resistant to that class of antimicrobials?
Until the moment, no, because we have a preliminary results, and we have to continue with this study.
Right, and
I have a comment from my part. Is that I personally I think that resistance patterns or resistant pattern is something of microorganisms to antibiotics is something neglected in the field of bronchiectasis. And I think that's especially useful probably for chronic treatments and for acute exacerbations.
And another question, I noticed that quite a lot of the strains were resistant to injectable agents but sensitive to quinolones, whereas in CF it's usually the ones resistant to injectable are also resistant to quinolones. So do you have any thoughts on that? Is that because of antimicrobial use that is different from in bronchiectasis than CF?
I don't understand. Will you repeat again, please?
Yeah.
So many of the strains were resistant to imipenem, meropenem, injectable agents, and sensitive to quinolones. Whereas usually we see that the ones that are resistant to the injectables are also resistant to quinolones. This is not the case, obviously, in your data. So do you have some explanation? Or just that it's a different mechanism of resistance?
Roberto, do you?
Yes.
Yeah, did you understand the question? Yes. Yes. No. Mitchell is asking, está preguntando por qué en la fibrosis quística hay siempre, muchas veces, resistencia a quinolonas. ¿Y por qué aquí son sensibles? Los fibróticos, los con cystic fibrosis, reciben muchos más antibióticos, ¿eh? Si lo quieres.
Well, I don't know why you say that they don't have resistance to fluoroquinolones, because in the...
No, I say they do in CF.
Maybe the other patient receive more quantity of antibiotic.
Okay.
Tobias here. I think the main question with fluoroquinolone resistance is what is the administration route? So is it IV or oral antibiotic, or is it inhaled antibiotic? Because all the resistance thresholds are not true for inhaled antibiotics. And then it's a question of dosage. So if there's high dosage, even it is a resistant strain, you can achieve concentrations which are above the resistance threshold. Yeah. However, mainly with ciprofloxacin, if it is systemically high dose, there are a lot of side effects. So for inhaled treatment, in my mind, fluoroquinolones are a very interesting option, and it's unfortunate that they failed in the clinical studies. For IV, we in Germany now, we are more and more cautious to use it as regular treatment in any way.
Because the warning, no? The global warning of quinolones. Yeah,
because of the global warning, but also because of the increase in the mean MIC for Pseudomonas. So, and then you have to increase the dosage, and if you increase the dosage, you have more side effects.
Okay. So Tobias, do you want to introduce the next?
Oh, I think Michelle should do, and I
Okay.
will only interact in the discussion.
Thank you. So
So
Michelle.
I'll introduce the next speaker. It's Gyam Yan Hu from the UK. I'm hoping I'm not mispronouncing the name. Validation of AMP activated protein kinase as a therapeutic target in bronchiectasis. Can you share your slides, please? Yes, hello.
Hi, can you?
Yes, we can see your slides. You can go on.
Is this the right one that I'm sharing? Yep.
Presentation mode. Yeah, this is perfect.
Okay, thank you for the introduction. I'm Ashley from the University of Dundee, and I'm a second-year PhD student. And firstly, I'd like to thank the organisers for such a wonderful opportunity to present my project. So I'd like to talk about validating AMPK as a new target for bronchiectasis, which focuses on, next slide. Okay, right. Which focuses on neutrophil extracellular traps or NETs release in bronchiectasis. And even though the mechanisms to this dysfunction is still unknown, studies have suggested that metabolic reprogramming in neutrophils could be causing this. And in bronchiectasis, inflammatory factors in the airway also disrupt mucociliary clearance as well. So since ciliary beating requires ATP, we also want to understand the metabolic reprogramming in nasal cilia. And hence, we want to study the energy sensor kinase, which is AMPK, in both cell types. So we hypothesize that AMPK inhibition in neutrophils increases netosis, and whereas in nasal cilia, AMPK inhibition leads to poor mucociliary clearance, and we think that activating AMPK would then restore the ciliary function. Right. So firstly, let's talk about the bridge pilot study. We've collected soluble sputum from bronchiectasis patients and measured various inflammatory cytokines and also the two metabolites, which is lactate and glucose. And we see here that lactate correlates with neutrophil elastase, CXCL8, resistin, and MMP9. And this is a heat map that summarizes all the p-values of correlation of lactate and glucose versus all the other inflammatory cytokines. And we see that lactate here correlates strongly or correlates with the neutrophil-related proteins more. And since lactate is a marker of metabolic reprogramming, we think that there is a metabolic reprogramming in neutrophils during inflammation. So then moving on to the next part, we also isolated neutrophils from whole blood and treated them with AMPK inhibitor resistin and then stimulated with PMA to induce NETs production. And we see that the resistin-treated neutrophils have increased NETs production, and this supports our data from BRIDGE, whereby the H1 elastase, which is a NETs marker, is also elevated in samples of high lactate and also strongly correlates with resistin as well. And then moving on to the cilia part of the study, we also measured, we stained for AMPK in nasal brushings collected from patients, and we see that AMPK is highly expressed in the ciliary portion. And then we also further treat these cultures with AMPK inhibitor. So we use compound C and resistin, which are both AMPK inhibitors, and we see that there's a reduce in nasal ciliary beat frequency or CBF. And then furthermore, looking at metabolic reprogramming, we also inhibited glycolysis with 2-DG, and there's a sustained decrease in nasal CBF. And when we add A769662, which is the AMPK activator, it actually recovers the ciliary function back to baseline. So to conclude, our data suggests that there's presence of resistin and high glucose in bronchiectasis airway, which can inhibit AMPK, and it slows down nasal cilia and increases netosis, both of which are central features of bronchiectasis pathophysiology. And in the case of nasal cilia, we see that when you activate AMPK, it has the therapeutic potential of that. Thank you so much.
Yeah, thank you for a very nice paper. I want to start with a question. So where is AMP activated protein kinase in the organism normally? Is it something, if you inhibit it, if you activate it, it's a systemic activation which affects other organ systems and other cell systems, or do you think it's very specific in nasal or airway celial cells?
Thank you for the question. So AMPK is an intracellular protein that's expressed in every cell type, almost every cell type, I think. So any AMPK activators has to first enter the drug in order to interact with AMPK enabled, in order to activate it. And normally physiologically in the cells, it will be activated by AMP, which binds to the protein AMPK, which then allows it to be phosphorylated by other kinases. So that's how it gets activated. Yeah.
Yes, I have another question. Please let us know which are the potential clinical implications in future treatments.
So I think for activating AMPK, because there is already a drug, AMPK activator drug, which is metformin, that's already used for type 2 diabetes treatment. So I think for future implications, it would be really nice if we could have a trial where we try to see if metformin is also beneficial for bronchiectasis patients. Yeah.
So can I comment that elevated blood glucose has been associated with a reduction in lung function, not in bronchiectasis, but in other diseases, CF, but also other lung diseases. So this may be one of the mechanisms. It's really interesting.
Michelle, do you think it's blood glucose or it's something else which is related to diabetes mellitus and metabolic disease?
Well, it's not only CF, it's a common mechanism.
Yeah, in COPD, this is a big debate about glucose or diabetes and progression of lung deterioration. So
yeah, one of the theories that it's the airway surface liquid glucose levels that are directly doing this, but there's probably other metabolic consequences. You're absolutely right. It's really difficult to isolate the mechanism.
Okay, thank you very much. We have to move on, and now we are going back to two posters from the same author, Atanasio Rodrigo Avensur, and the first one is automated computed tomography lung densitometry in bronchiectasis patients.
Hi,
Please, Rodrigo is the first name.
Yes.
Yeah, Rodrigo.
It's good morning. It's still morning here in Brazil, and I'm very sorry about the delay.
Full screen.
Yes.
Yeah.
Is it fine
perfect.
now?
Yes, that's okay.
Okay, and sorry for the delay, but I was stuck in the hospital due to the pandemic. Is still here in Brazil, a little bit hard.
Not worries.
Okay, so I'm going to present first this our work on behalf of my colleague, this automated complete tomography lung densitometry in bronchiectasis patients. It's a work done in the University of São Paulo. So first of all, we already know that bronchiectasis is a heterogeneous disease, and as is its pulmonary involvement and related tomographic findings. And we know that visual computed tomography scoring systems are used to assess disease severity and predict outcomes in bronchiectasis. However, they have some limitations, such as subjectivity and requirement of previous training, and are very time consuming until now. So the objective of our study was to correlate quantitative CT lung densitometry measurements with lung function and severity in patients with bronchiectasis, and also compare their accuracy with usual CT score systems. So we include adult patients with non-cystic
I'm sorry, can people mute who are not talking mute because we hear another noise?
Okay. So we include adult patients with non-cystic fibrosis bronchiectasis that underwent inspiratory and expiratory volumetric chest CT, lung function, a complete test with spirometry, plethysmography, and diffuse capacity test. We assess the severity of disease by both BSI and FACID scores, and use some CT lung densitometry parameters that would be the kurtosis and skewness, and the expiratory inspiratory ratio mean lung density that were calculated with for all patients and compared with the CFCT visual score. So in generally, our population were mainly female patients with a mean age of 43 years old. The majority of cases were idiopathic with a very impaired lung function, the mean FEV1 of 49%, and they have also some air trapping that you can see in the plethysmography. When we made the correlations between the spirometry and visual CT score and also the automated CT lung score, we can see a very good correlation between FEV1 and some expiratory inspiratory mean lung densitometry, and also with the CFCT visual score. This was also true for the FEV1 and also the relationship of FEV1, FEVC, that's showing that all obstruction measurements were correlated with the visual and also automated CT score. When we went to the plethysmography to see volumes, we can see here also a very good correlation between the expiratory inspiratory mean lung densitometry with the residual volume, and also with the air trapping measurement by the residual volume and the total lung capacity. And again, we can just check here that also the visual score had good correlation, but not as good as the automated computer tomography findings. Finally, we also made this correlation with the severity scores, and we can see here that both BSI and also the FACID score had a very good correlation with the expiratory-inspiratory relation of the automated computed tomography that were much better than the one that you have with the CFCT score, the visual one. The automated computed tomography lung densitometry was faster than the visual CT score as we expected. And also we had a very good accuracy of the CFCT score and the automated relationship of expiratory-inspiratory mean lung densitometry to identify more severe patients that were classified as moderated to severe in the FACID score, so that we can also use this measurement to assess severity of these patients. So in conclusion, CT densitometry is a fast and simple method of automatic quantification of lung disease in bronchiectasis. This method correlated well with multiple lung function tests and multidimensional prognostic scores. And finally, expiratory-inspiratory mean lung density performed better than visual scoring system to discriminate more severe patients. Thank you.
Thank you very much, Rodrigo. Nice work. Congratulations as well. And I want to start with a question. These were patients in a stable condition, eh?
Yes.
Yes, okay. My question, did you try to correlate this with quality of life?
We don't have this measurement in this study, but it's really something that we would do. We started these patients as a cohort, so we're going to reassess these patients 3 years later. So that's something that we can include in our assessments.
Thank you. Michel or Tobias, do you have any question? Hello?
I do not have a question, so very nice presentation.
Yes.
Thank you.
Okay, so in conclusion, your work shows that this system, automated system, performs better when you want to compare the CT findings with the severity scales and the lung function, and better than the visual information of the CT scan. No? Is that the summary?
Yes, that's true.
Okay.
And I think it's a very interesting finding because we know that the visual score, they also have other measurements of MUX plugin, the bronchial thickness, and we do realize it's important features of the disease. But this study shows us that the bronchiectasis is an obstructive lung disease, and the obstruction and the air trapping may be one of the most important information to correlate with the lung function and also for severity of the disease. And other quantitative measurements, for example, the skewness and kurtosis, they didn't have a very good performance as the expiratory-inspiratory ratio that was much better to correlate with severity. So I think that the most interesting finding here is that air trapping is really one of the most important features in bronchiectasis as an obstructive lung disease.
Okay. So,
So-
now go ahead, please, Michelle.
Oh, thank you. Sorry. And you were saying that you are following these patients over time and seeing longitudinal CT measurements.
Yes, we're going to start the assessment right now with 3 years. It's we're starting the cohort like 2 years ago, and we're going to reassess this patient right now. We still don't have any data about this.
Yeah, so it would be interesting to see if the more severely affected patients also, or the more severe CT scans also exacerbate more.
Sure, I think this is we have this information about previous exacerbations in the air trapping measured by the CT densitometry correlated with the previous exacerbations, but for sure, I think it's better to see how it's going to be prospectively.
Okay, thank you very much. Let's move to your second poster presentation, Dynamic Hyperinflation and Exercise Intolerance in Bronchiectasis, Clinical, Radiological, and Functional Correlation.
Okay, can you see the slides?
Yes.
Yes.
Okay. So about this study, so first of all, our rationale was that exercise intolerance is a frequent finding in patients with bronchiectasis. And since it's an airway disease, dynamic hyperinflation may be one of the mechanisms involved to dyspnea and exercise intolerances in these patients. The prevalence of dynamic hyperinflation in bronchiectasis is unknown, as are factors associated with its occurrence. So the aim of this study was to evaluate the prevalence of dynamic hyperinflation in adult patients with bronchiectasis. We included 114 patients diagnosed with bronchiectasis in a stable condition that underwent a cardiopulmonary exercise test, complete pulmonary function evaluation, forced oscillometry, and high-resolution computed tomography. And here we evaluated by the RAFE score. Inspiratory capacity during exercise were evaluated and correlated to clinical function and tomographic data. Inspiratory capacity were the measurement that were done during the cardiopulmonary exercise tests to assess dynamic hyperinflation. And dynamic hyperinflation was defined as a drop in inspiratory capacity by more than 10% during the cardiopulmonary exercising test. So the results, our patient characteristics also have these patients that a mean age of 43 years old, a normal body mass index, a majority of female, idiopathic is the first cause, the principal cause of bronchiectasis. The majority of patients, they were non-colonized, with almost 20% of patients colonized by Pseudomonas aeruginosa. And these patients had a mean exacerbation rate of 1 exacerbation in the previous year. As you can see, the severity scores here, the majority of the patients, they were moderated to severe cases. So the prevalence of dynamic hyperinflation in the study was almost 70%, 68.4% of the patients presented with dynamic hyperinflation in the study. And when we compared some data between patients with dynamic hyperinflation with those that didn't have dynamic hyperinflation, what we can see here that several lung functions parameters were different between both groups. So here we can see that patients with dynamic hyperinflation, they had much more impaired lung function measured in both by the spirometry as the also measurements from the plethysmography. And also we can see here with the oscillometry measurements that the total resistance in the airways were greater in the patients with dynamic hyperinflation. And also when we saw the small airways involvement by the R5 minus R20 that assess small airways involvement, we can see here that the majority of the resistance was due to the small airway commitment. Here we can see the correlation between respiratory capacity with several other measurements of lung function. So we can see here very good correlation between FEV1 and respiratory capacity variation during the exercise test. Also, air trapping had a good correlation, as also oscillometry measurements of the small airways and also the exercise capacity by the VO2. So in conclusion, the prevalence of dynamic hyperinflation during cardiopulmonary tests in patients with bronchiectasis is high. It is associated with worse lung function and disease severity. FEV1 was the main factor associated with this condition, and understanding the mechanisms involved in exercise limitation of these patients is essential to identify new therapeutic targets for the management of bronchiectasis. We know, for example, that bronchodilators is still something that we don't have a lot of evidence in bronchiectasis, and maybe these physiological studies may show a very good pathway to use these medications. Thank you.
Thank you very much, Tobias and Michelle and Tobias. Do you have questions for Rodrigo?
I have, maybe I've missed it in your previous poster, but what was the best determinant on CT of dynamic hyperinflation? Was it mucus impaction, or did you find a correlation to so because I wonder what the therapeutic target or what the therapeutic mechanism might be.
Yeah, from the previous study, we used the measurement was air trapping measured by the expiratory-inspiratory ratio lung densitometry. We're still not able to make these correlations with dynamic hyperinflation. So that's the next step that we really want to do is to assess air trapping by the CT measurement, because here we are just have the RAFE score that is much simple measurement of bronchiectasis, and it didn't have a very good correlation. The RAFE score with dynamic hyperinflation, the measurements with lung function were much better than RAFE. But I do believe that when we made this with automated score systems, going to be better correlated.
I also have a question. So I missed what the exercise capacity was. Is dynamic hyperinflation related to the maximal exercise capacity, and does it occur with higher exercise levels after longer times, or with more exercise on the cycle, or is this independent?
Yeah, very good question, and it's very interesting because I didn't have had time to show all data, but it's when we have a weak correlation between dynamic hyperinflation with the maximum VO2 in the exercise capacity test. But it's when we did multivariated regression to see what were the main mechanisms of each variation, we see that for dynamic hyperinflation, FEV1 was the best variable to determine these characteristics in these patients. But when we did and go to the maximum exercise capacity by the VO2, the best predictor of maximum exercise was the GLCO. So we know that bronchiectasis is a very heterogeneous disease, and probably we have both airways and also parenchyma disorders that we have in these patients. It was very interesting to see what kind of variable were more correlated to each of these characteristics, that's exercise tolerance and dynamic hyperinflation.
I have a second question. Are the patients on bronchodilators, and is it with bronchodilator therapy, or is this treatment naive patients?
No, these patients, they were treated in the rotaling practice, and we do use a lot of bronchodilators for these patients. So the data that we have, that at least 8% of these patients were using a LABA, and 30% were LAMA, using LAMA also.
Yeah, I have one question as well. Perhaps this is the explanation why when we give bronchodilators to bronchiectasis patients, sometimes work and sometimes not?
Actually, I have the idea that bronchodilators, sometimes not all patients going to benefit from some treatment, and we can have some patients, for example, with COPD, that's not going to have a very good increase in symptoms when we use some medications. But here for sure, I think that bronchodilators is very useful to increase exercise capacity in these patients, since dynamic hyperinflation is very present in this, very common in these patients. But I think that even patients without dynamic hyperinflation, that is the more severe patients, may also benefit from bronchodilators in less magnitude, but I think it can also work.
I think these are very important data, because we very often avoid anticholinergics because of the increase in sputum viscosity. But in terms of dynamic hyperinflation, anticholinergics are much better than beta mimetics. So if this is a so common feature, we should think again whether anticholinergic treatment should be given more often.
I totally agree.
So thank you very much, Rodrigo. Michelle, can you take? Can you present the next speaker, please?
Yes, I think this is Karamuz Elham from the United States, pulmonary hypertension and bronchiectasis. Yes. So we see your slides. Are you muted? Ellie?
Hello, sorry.
Okay.
Thank you. Yes, my name's Ellie Karamuz. I'm a pulmonary critical care physician at Oregon Health and Science University, and I'm presenting some work I did with my mentor and other colleagues regarding pulmonary hypertension and bronchiectasis. So pulmonary hypertension is a morbid complication in patients with bronchiectasis. And the goal of our study was to identify clinical factors associated with an elevated pulmonary artery to aorta diameter in patients with non-CF bronchiectasis. And the reason we chose CT-based measurements for identifying pulmonary hypertension is that CT scans are often obtained in the evaluation of patients with non-CF bronchiectasis, whereas echo data might not be as well reported. We use the US Bronchiectasis and NTM Research Registry to pull clinical data on 321 patients with non-CF bronchiectasis. CT scans were scored for severity of bronchiectasis by a thoracic radiologist using modified Reef criteria. And then pulmonary artery and aorta measurements were made off those CT scans. Table 1 shows our cohorts, characteristics of predominantly female, 83.2%, heavily tilted towards NTM as far as bacterial sputum cultures, with 57.6% showing NTM, and then another 16.8% showing NTM and Pseudomonas. Figure 1 shows how the modified Reef score by lobe kind of broke down. And as you can see, that scores of 2 and 3 are more severe, and those were found predominantly in the right middle lobe and the lingula, which seems consistent with the high degree of NTM disease we had in our cohort. So figure 2, we looked at the association between sputum culture or modified Reef criteria and PA-AO ratio. And we found no association between elevated PA-AO ratio defined by a ratio of 0.9 with sputum culture or any association with the modified Reef score. However, the most significant clinical factor that was associated with an elevated PA-AO was, in fact, oxygen use. Also, oxygen use did correlate with a more significantly elevated modified Reef score. And so our conclusions are that supplemental oxygen was clearly the most strongly associated clinical factor that was associated with an elevated PA to AO. And we think this might help stratify our patients who may need additional workup for pH. Limitations of this study are that it was retrospective in nature and highly tilted towards NTM disease, which is not the case across other centers. So I think it would be quite interesting to look at data other centers and see how it breaks down. And I'd like to acknowledge my colleagues as well as the COPD Foundation provided a grant for this work. Thank you.
Ellie, really nice
Yes.
work. And did you look at correlations to lung function between the ratio of aorta to pulmonary artery and lung function?
We did. We looked at the lung function data that we had in the bronchiectasis research registry was FEV1s and FVCs and ratios. We did not have DLCO data available. And I think that would have actually been the most helpful. But we did not see a significant association with the FEV1 and FVC ratios.
I did not understand the method of detecting pulmonary arterial hypertension in CT scans in detail. So what is the correlation with normal right heart catheterization values?
So there have been a couple of papers and reviews that have found, more specifically in patients with COPD, that elevated pulmonary artery diameter to aortic diameter ratios are associated with elevated pulmonary artery pressures on right heart catheterization. The ratio is sometimes reported as greater than 1. However, there have been some studies looking at that say that a ratio of 0.9, in fact, above 0.9 is abnormal, which is why we use that cutoff.
In terms of what you showed as diameters, what would be the equivalent in pulmonary artery pressures?
So a ratio of greater than 1, I think, would be associated with, if I go back to the study that looked at the COPD patients, you're looking at pulmonary artery pressures, I believe, greater than 30, the mean pulmonary artery pressures.
Okay.
But I have to double check that. Thank you.
30. I have a question. These patients that have this, let's say, mild pulmonary hypertension, no?
Yes, absolutely.
Bronchiectasis and mild.
Yes.
Is there any rationale to treat this pulmonary hypertension on them?
I think that has not been borne out in the data of treatments of group 3 pulmonary hypertension, particularly with some of the newer oral agents, that has not shown to be beneficial.
Okay.
I think what could be beneficial in them is still hard to know for sure.
Okay, thank you. So thank you very much. Very nice work as well. Michelle, can you go ahead?
Yes, so I think the next poster is an interesting title. It's Innovative Bronchiectasis Education and Primary Care by Isabella Clerc. And sorry for not doing the exclamation marks, but you do it.
Can you see my screen?
Yes.
Yes.
So hello, good morning from Canada. My name is Isabelle Leclerc. I am a registered nurse working in primary care at the Briere Academic Family Health Team in downtown Ottawa, which is the capital of Canada. So over the past 8 years, our Family Medicine Center has developed expertise in registered nurse-led self-management programs for chronic diseases like hypertension, heart failure, and chronic non-cancer pain. Back in 2016, we used this experience to build an innovative nurse-led self-management program for adults with bronchiectasis with the goal of improving their quality of life and their patient experience. So we first started by building a registry using our electronic medical records. So the registry is reviewed by the nurse, which is me, to identify patients eligible for the self-management program. Now, since January 2019, the program is now offered to all adult patients in the Greater Ottawa area, and these patients are referred by local respirologists, and that would mean a 200 square kilometer area. So patients have an initial visit, and then a follow-up visit 3 months later, and then once annually, but as well anytime in between. During COVID-19, the visits are done by phone or secure video. Patients are provided education on what is bronchiectasis, what are the treatment goals, the definition of a bronchiectasis exacerbation, and when to take the rescue antibiotics to prevent hospital visits. So topics discussed include nutrition, hydration, exercise, smoking, caffeine, alcohol, airway clearance techniques, including OPEP devices, prevention of environmentally acquired antibiotic resistance bacteria like NTM and Pseudomonas, and a bronchiectasis action plan is also provided. Now, outcome measures include age, gender, body mass index, FEV1, number of visits per patient, quality of life, and I use both the quality of life bronchiectasis as well as the bronchiectasis health questionnaire. Dyspnea using the MRC breathlessness score, confidence to achieve their goal that I use with every self-management program, patient satisfaction, and the use of a OPEP device pre and post patient participation. So when we look at the results, we can see that 68% of patients participated to the program, 46% were referred by local respirologists. The average age of the patient is 70 years, ranging from mid-20s to very late 90s, and 71% are female. Each patient had an average of 4 visits. Now we look at the average score of the bronchiectasis health questionnaire, which is 58%, indicating patients' perception of moderate bronchiectasis. It truly does correlate with the average score of the bronchiectasis severity index, which is 6 for moderate bronchiectasis. 36% of patients used an OPEP device before the program participation, but now 83% are using an OPEP device. They have learned how to use it properly and how to clean it. So self-management education in primary care has truly encouraged, motivated, and given patients a choice in choosing lifestyle changes to improve their quality of life. Ongoing support by a registered nurse in primary care can be done until and during the time of palliative care. Now, last year, in November 2019, Ottawa held the first bronchiectasis and NTM workshop for healthcare professionals, and I now provide bronchiectasis educational workshops and webinars for healthcare professionals in Canada. So we also give patient satisfaction surveys, which are completely confidential. I give them out to them, but they are not returned to me. And there was one patient who you can see in the description here about her participating to the program and what it did to her life. And this actually, you can find this online. There was an article published on this patient story. And if you Google my name and just add bronchiectasis, you will get her story as well as why I chose to develop this program. So I really want to thank all of you for listening to my program description, as well as our administration, who has always given me carte blanche to develop the programs that I wanted to develop. Thank you.
Thank you.
Thank you.
Can I go ahead with a comment and a question?
Yes, of course.
The comment is that I really envy the pulmonologists that are working with you for having this resource to refer. And the question is, do you have also online videos and resources that you refer the patients to?
So I give them a lot of, when they were coming in the clinic, I would give them a lot of handouts that I would print. Right now, everything is done by phone. So I do refer them to the British Thoracic Society. I refer them to the Bronchiectasis Toolbox out of Australia. And I do refer them, we have here in Canada something called Living Well with COPD. And they had just developed a new module online that patients can go to learn about airway clearance techniques. And I was part of that that development of that that article and for patients. So they are online. And I do refer them to something called NTMIR, which is Non-Tuberculosis Microbacteria Information and Research. There is an American chapter, but we also have a Canadian chapter. And they now, this group of support for patients and education for patients in Canada, they meet with Zoom, which is quite wonderful. And there's two respirologists in Toronto that you may know, Dr. Maris and Dr. Brody as well. And myself, we kind of rotate giving the patients education.
And thank you. I have a comment about the poor sensibility or that at least in our country to the nurses that work for bronchiectasis. They do not want to invest in the hospital and the health responsibles in that is just a comment. And I think that the role of the nurses is really very important for the patients, and your program is a demonstration of that.
I absolutely agree. So thank you very much, Isabel, and I think we can, if there's no further questions, can we go on to Lottie Terpstra from the Netherlands, effects of long-term tubramycin inhalation solution once daily on exacerbation rate in patients with non-cystic fibrosis bronchiectasis, the BATTLE randomized control trial. So Lottie, please go ahead.
Yes, I'll share my screen.
Yes, perfect.
See it? Okay. So hello, I'm Lotte Terpstra from the Netherlands, Northwest Clinics in Alkmaar, and I would like to present the first results for a BATTLE randomized control trial, the effect of long-term tobramycin inhalation solution once daily on exacerbation rate in patients with non-CF bronchiectasis. As we know, long-term inhaled antibiotics and also tobramycin inhalation solution are the standard care in cystic fibrosis bronchiectasis. In non-CF bronchiectasis, studies with inhaled antibiotics and particularly inhaled tobramycin inhalation solution are limited, but suggest a benefit. And in this placebo-controlled trial, we will investigate the effect and safety of maintenance tobramycin inhalation solution on the frequent extubating bronchiectasis patients colonized by different pathogens sensitive for tobramycin. The primary objective of our study was a 50% reduction in number of exacerbations using maintenance tobramycin as compared to placebo. And our secondary objectives were time to first exacerbation, change in lung function and quality of life, microbiological evaluation, and of course, the safety assessments. Our study was conducted between 2016 and 2019 in 6 hospitals in the Netherlands. Patients aged above 80 years old were included with at least 2 exacerbations in the preceding year and 1 positive sputum culture for gram-negative pathogens, but also Staphylococcus aureus in the preceding year and also at baseline. After randomization, patients received tobramycin inhalation solution once daily or placebo, which was saline 0.9%. during 1 year, and patients visited the outpatient ward every 3 months. So the results of our study. From the 58 patients, a total of 52 patients were included in the modified intention to treat population. 26 patients were treated with tobramycin and 26 patients received placebo. The number of exacerbations for the patients who received tobramycin was 3.8 before the study and 1.5 after the study. But also the placebo-treated patients showed a decrease in number of exacerbations with 3.8 exacerbations before the study and 2.2 exacerbations during the study. And this resulted in a non-significant decrease in number of exacerbations for patients treated with tobramycin as compared to placebo. And we found a risk reduction of 26%. Also, time to next exacerbation differed between both groups, with a mean of 29 weeks for patients treated with tobramycin and a mean of 21 weeks for patients treated with placebo, and resulted in a hazard ratio of 0.64. The other secondary endpoints, lung function, quality of life, showed no significant differences between both groups. So in conclusion, a decrease in number of exacerbations for patients treated with tobramycin was found as compared to placebo, with a risk reduction of 26%. However, the placebo-treated patients also showed a decrease in number of exacerbations, and we found an increase in time to next exacerbation for patients treated with tobramycin, with non-significant differences in lung function and quality of life for both groups. So thank you for your attention. So at the end.
Thank you so much. I have a question. A question is, you did not report the microbiology here.
Not yet.
Ah, not yet.
Not yet.
But this is important. What type of microorganisms were infecting these stable patients? No.
Most people were colonized with Pseudomonas aeruginosa and Haemophilus influenzae. And the biggest group.
And at the end, or in the midterm, what happened with the resistance? And of course, again, this is the issue of the resistance to IV antibiotics.
Yeah.
The MICs, did the MICs change?
Our first analysis showed no resistance, but we are waiting for the final results from our analysis from the microbiological evaluation.
Thank you.
And well, I think you will present the microbiological results later, but yes. What you know now, is there a difference between Haemophilus and Pseudomonas?
Yes, we found there was at the end some patients colonized with Pseudomonas aeruginosa. The tobramycin did the work. We found no Pseudomonas at the end of the study, and the Haemophilus we found also at the end. So we think, and also in the cystic fibrosis bronchiectasis, Pseudomonas works. Of tobramycin inhalation solution works better for the Pseudomonas population. However, there was no differences in number of exacerbations between both groups. Haemophilus colonization did also well with tobramycin.
Okay, thank you.
So I think we're nearly out of time, and we're coming up for the last poster. I'm sorry, and this is Dr. Mantila Jarkko from Finland. Poor physical capacity in bronchiectasis patients is correlated with poor quality of life. So please go ahead.
Did you see my slides?
Yes.
Yes.
Okay, so my name is Jarkko Mantila from Helsinki University Hospital in Finland. We wanted to evaluate which are those factors for poor quality of life in non-cystic fibrosis bronchiectasis patients. We had altogether 95 voluntary adults with diagnosis of bronchiectasis made by high-resolution computed tomography, as you see from the figure 1. We use different kind of scores to evaluate patients' situations, such as disease-specific quality of life bronchiectasis questionnaire and bronchiectasis severity index and facet score and modified medical research council dyspnea scale, such as MMRC score. So the results altogether, 23 patients had poor quality of life and 69 more perceived quality of life, and missing information were only 3. As you see from the table 1, patients with frequent exacerbations, I mean 3 or more per year, had significantly poorer quality of life, poorer lung function, and poorer physical tolerance, and more severe disease than patients with less exacerbations, which I mean 0 to 2 per year. As you see from the table 2, 4 factors have statistical significance related to the poor quality of life. First one, frequent exacerbations with odds ratio 5. The second one, extensive disease with odds ratio 3.7. And the third one, high score of bronchiectasis severity index. And the fourth one, high score of MMRC with odds ratio 3.4. So the conclusion, although the cohort was relatively small here in Finland, we found that exacerbations, especially frequent exacerbations, increased the risk of poor quality of life to 5-fold. In addition, more extensive disease or greater severity of disease increased the risk of poor quality of life as well. When looking for strategies to improve quality of life in bronchiectasis patients, the cornerstone should be on preventing exacerbations and supporting physical fitness to reduce exercise-induced dyspnea and support patients' ability to cope in daily life activities. Thank you.
Thank you.
So, any questions?
Only a comment. I think that's quite true, and real exacerbations have a major impact on life quality. So this makes it more important to reduce the number of exacerbations. So exacerbation prevention is a major issue in bronchiectasis.
It is, indeed.
So I think we are ready to close this poster session. I think Tobias or Anthony, would you like to close the session?
Tony, if you agree, I will give some final remarks. So I think
yes, please, Tobias.
This was a really fantastic session. Very good presentations, good observations, new observations, which could be used as hypothesis for future trials. Some trials like the topramycin trial out of the Netherlands. So really fantastic work demonstrating how many good clinical science is now in the bronchiectasis field. And I want to thank everybody presenting here under this very special circumstance. And I want to express my best wishes for 2021. And I hope very much, and I think this is the same for Michelle and Tony, that we could meet again in 2021 face to face. Yes. So thank you very much. You did a great job. Thank you for being here. And if we do not meet again during this conference, Merry Christmas and all the best for 2021.
Thank you very much, Tobias. Thank you. Goodbye. I don't know, Tobias and Mitchell, if we have to stay for a vote, or is that individual?
No, I think it's individual.
It's
Okay.
individual.
Everyone
you.
votes for his own self. So thank
Yeah.
you and good night, everyone.
Okay. Goodbye.
See you tomorrow, huh? Tony, see you tomorrow.
See you tomorrow for sure. Eh?
Yeah.
Okay.
Bye.
I am writing the editorial, Tobias.
Yeah, I will send you the comments from the other reviewer. Yeah.
Please, that's
I
important.
do it tomorrow.
Okay. Goodbye. All my
Bye.
best. Bye-bye.
Bye, Michelle.
Goodbye.